My name's Dr. Andy Lee, and I'm the neuro-ophthalmologist here at Houston Methodist Hospital. And today we're going to be talking about internuclear ophthalmoplegia. And that is quite a mouthful, internuclear ophthalmoplegia. But really, if you just take it apart, it's a plegia, a weakness of ophthalmo, the eye movement, and it's between two nuclei. The two nuclei that form the internuclear ophthalmoplegia, INO for short, one begins in the pons, and this is a cross-section of the pons, and that is the number cranial nerve 6 nerve nucleus. And the 6th nerve has to talk to the midbrain, and the midbrain has the cranial nerve 3 nucleus. So cranial nerve 6 has to talk to cranial nerve 3, and the structure that allows that communication to occur is called the MLF, the medial longitudinal fasciculus. It's medial because it's towards the midline. It's longitudinal because it runs up and down between the pons and your midbrain. And it's a fasciculus, which means it is a white matter tract that carries the information between the two nuclei. So the nuclei of 6 and the nuclei of 3 have to talk together. And the reason they have to talk together is when you have your eyes and you want to look, for example, to the left, you must fire this muscle here, which is the left lateral rectus, which is innervated by cranial nerve number 6, and that has to be linked to the firing of this eye, the right eye, so that the right eye medial rectus can fire, so that the two eyes can move together. So the right eye medial rectus has to fire with the left eye lateral rectus, and to get those two eyes to move together, they have to be connected between their two nuclei, internuclear, and if you have a disruption of that connection because you have damaged the medial longitudinal fasciculus, that problem causes ophthalmoplegia, and that ophthalmoplegia is called internuclear ophthalmoplegia, INO for short. So what happens when you disconnect the 6th from the 3rd, the eye cannot adduct, and the lateral rectus keeps firing, and so you get this dissociated horizontal abducting nystagmus. So it looks like this. You're trying to look to the left. The eye on the right cannot adduct. The left eye has a horizontal jerk-beating abducting nystagmus. When you look to the right, you're fine. So the name of this thing is INO. It's from MLF. And in a young person, the most common cause is multiple sclerosis. But in an older person, the most common cause is a stroke. However, because you don't know what the lesion is, you have to do a CAT scan if it's acute, and then you're going to do an MRI, and you're going to be looking for a medial longitudinal fasciculus lesion, either demyelinating from MS or a stroke in an older patient, especially if they have vasculopathic risk factors. You should also know that it doesn't have to be a lesion in the MLF because it can be a pseudo-INO, and pseudo means it's not really an INO, it just looks like an INO. And so if you have an adduction deficit with an abducting nystagmus, it could still be a pseudo-INO, and that is usually from myasthenia gravis. So we need to look for a lesion in the brain in an INO. We got to consider the myasthenia gravis pseudo-INO, and you should know that an INO is a lesion in the medial longitudinal fasciculus.